Hello everyone. So we'll be talking about the abscesses of the periodontium and how they're supposed to look like. So periodontal abscess is a localized purulent inflammation of periodontal tissue and classified into gingival, periodontal, and pericoronal abscess. The gingival abscess involves the marginal gingiva and intestinal tissue. Periodontal abscess is an infection which is located adjacent to periodontal pocket and result into destruction of periodontium. And the pericoronal abscess is associated with crown of partially erupted tooth. So for periodontal abscess, it is typically found in patients with untreated periodontitis and it arises as an acute exacerbation of a pocket and it's primarily related to incomplete calculus removal. So it is condition in which periodontal abscess is not related to inflammatory periodontal disease include tooth perforation, fracture or foreign body impaction. Apart from that, poorly controlled diabetes mellitus has been a predisposing factor for abscess formation. So this is how an abscess looks like, which is a collected area having pus and it shows signs of inflammation and enlargement. So if it is an acute abscess, patient will perhaps discomfort, localized swelling, pocket mobility, the tooth is elevated in its socket, tenderness to percussion, exudation, elevated temperature, and regional lymphadenopathy. However, in chronic abscess, there is no pain or there is a dull pain. There is a localized lesion with slight tooth elevation, intermittent exudation that patient will complain. Pus oozes out and then it stops and then again it oozes out. There may be a fistula which is draining the abscess, leading into a chronic abscess, and there is no systemic involvement. Now, gingival abscess is a localized acute inflammatory lesion which arises from a variety of sources, including plaque infection, trauma, and foreign body impaction, and it appears clinically as red, smooth, or painful or fluctuant swelling. Pericoronal abscess results from inflammation of the soft tissue from the operculum, which covers a partially erupted tooth, and the situation is most often observed around mandibular third molars. As with gingival abscess, the inflammatory lesion may be caused by retention of microbial plaque, wound impaction, or trauma. So, how will we differentiate amongst the three? That is from periodontal abscess or periapical abscess, that radiograph has to be taken, complete history is must, and clinical examination will tell you which of them is present. So acute versus chronic abscess, they are usually categorized as acute and chronic. Acute is an exacerbation of already existing chronic periodontal lesion. Influencing factors include variety of factors which include number and virulence of bacteria present combined with lower tissue resistance and lack of spontaneous drainage. The drainage may have been prevented by deep tortuous pocket morphology, debris, or closely adapted pocket epithelium blocking the pocket orifice. They are usually painful, red, edematous, smooth, and ovoid. Exudate may be expressed with gentle pressure, and tooth is sensitive to percussion and feel elevated in the socket. There may be accompanying fever and lymphadenopathy. However, chronic abscess forms after spreading infection. It's been controlled by spontaneous drainage, host response, or therapy. And once homeostasis between host and infection has been reached, the patient may have few or no symptoms. A dull pain may be still present. Now, how will differentiate between periodontal and pulpal abscess? Periodontal abscess is associated with a periodontal pocket, so there will be a probing pocket depth. Radiograph shows periodontal angular bone defect. The tooth is vital. Swelling usually includes gingival tissue with occasional fistula. Pain is dull and localized, and sensitivity to percussion may or may not be present. However, with pulpal abscess or periapical abscess, offending tooth will have a large restoration, no periodontal pocket, no probing depth. Non-vital tooth swelling is usually at the apex with a fistulous tract, and patient often have severe pain and difficult to localize with sensitivity to percussion. Treatment: periodontal abscess need to be treated with drainage, usually with curettage. It's either incision and drainage at the most prominent point, or you do the curettage through the opening of the periodontal pocket. However, in case of cellulitis, fever, lymphadenopathy, or inability to provide drainage, systemic antibiotics are must. So you have to resolve the acute lesion followed by the management of resulting chronic condition. So we have to establish the drainage and the tooth has to undergo scaling and root planing, periodontal surgery if required, systemic antibiotics or teeth removal as such. For antibiotic therapy, When it has to be given in case of acute, if it is cellulitis, if the pocket is inaccessible, if there is a accompanying fever and regional adenopathy, and in case of immunocompromised patient. The treatment of choice is amoxicillin 500 mg, 1 gram of loading dose, and 500 mg 3 times for 3 days, and reevaluation has to be done after 3 days. Case of penicillin allergic patient, clindamycin 600 mg loading dose, then 300 mg 4 times a day for 3 days, or 1 gram loading dose and then 500 mg 4 times a day for 3 days. So in case of azithromycin, you have to use 600 mg. Now, treatment of chronic abscess. As with periodontal pocket, the chronic abscess is usually treated with scaling and root planing or surgical therapy. Surgical treatment is suggested when deep vertical or furcation defects are encountered. The patient should be advised of the possible postoperative sequelae usually associated with periodontal non-surgical and surgical procedures. As with acute abscess, antibiotic therapy may be indicated. Case of gingival abscess, you have to reverse the acute phase and immediate removal of the cause. Topical or local anesthesia by infiltration is administered. If possible, scaling and root planing are done to establish drainage and remove microbial deposits. In case of acute situation, a fluctuant area incised with number 15 scalpel blade and exudate will be expressed by gentle digital pressure. Foreign material, such as dental floss impression material, is removed. The area is irrigated with warm water, covered with moist case under light pressure. After 24 hours, the area is reassessed. And if resolution is sufficient, scaling not previously completed is undertaken. Case of pericoronal abscess, acute condition has to be managed and then anesthetized, and drainage is to be established by gently lifting the soil tissue upper column and periodontal probe or curate. If underlying debris is accessible, it may be removed following gentle irrigation with sterile saline. If there is a regional swelling, lymphadenopathy, or systemic signs, and antibiotics may be prescribed. Thank you.